Welcome to All Things Cardio-Oncology. My name is Steve Caselli. I'm the Executive Director of ICOS. And in this podcast, you'll hear from a diverse representation from our community. We want you to be both informed and inspired by their stories and experiences, and we're so glad that you've joined us today. As always, have my co-hosts with me today, Dr. Arjun Ghosh, consultant cardiologist at Barts Health Center and University College London. He also runs the Cardio-Oncology program there. Arjun, great to have you again.
Thanks so much for having me, Steve, and really looking forward to this episode.
And Dr. Dan Lenahan. Dan is the founding director of ICOS. He's also the director of cardio-oncology at St. Francis Hospital in Cape Girardeau, Missouri. So Dan, how are you today?
I'm great. Thank you. It's always great to be with our great friends. So thanks.
And we are delighted in this episode to welcome Dr. Hyeon-Ju Ali. She is assistant professor in the Department of Cardiology at MD Anderson Cancer Center in Houston, Texas. Today, we'll be speaking with her about pulmonary hypertension in cardio-oncology patients. She's done some research in that field, but before we jump into that topic, I wonder, Hyun-Jun, if you could just tell us a little bit about your personal background, how you developed your interest in cardio-oncology, and how you got started in this space.
Thank you so much, and thank you for having me. I am super excited to talk about this field that I'm very passionate about. My interest in cardio-oncology, I have to say, is very, very new. I did join MD Anderson this past year. Prior to that, my interest primarily was in pulmonary hypertension. Specifically, I got interested in it even as a medical medicine resident, looking at these very sick patients in intensive care unit, and was very humbled by how quickly patients decompensate in the setting of RV failure. Actually, as I was thinking about this podcast, one patient stood out in my mind. There was a transfer from an outside hospital, renal cell carcinoma, patient who seemed seemingly very stable on my interview, and then suddenly arrested later to find that, the patient passed with a tumoral embolism. And so thinking about these patients as I transitioned practice from an advanced heart failure center where I was for cardiology fellowship at Houston Methodist Hospital to a cancer hospital, I'm very humbled to see the prevalence of pulmonary hypertension in this population. And I think there's a lot to be learned about why patients with cancer might have higher risk for PH, and it's a great place to start off my career.
Fantastic. Thanks for that background. Arjun, I know you have a lot of experience with these patients. What are your thoughts on this question?
Yeah, so I think it's a really interesting topic that we've chosen for this podcast, and it's great that we have an expert in the field to guide us. And I think that no talk or podcast on pulmonary hypertension can get away from the definitions of pulmonary hypertension, which is obviously maybe the scourge of many medical students and many cardiology trainees. But maybe, Hyun-Ju, if you could just take us through the newest updated definition, and maybe which parts or which types of pulmonary hypertension may be most relevant for the cancer patient.
Yes, no, thank you for that. I think that, we need to first accept the fact that pulmonary hypertension definitions have evolved a lot in the past decade through many guidelines, the latest of which is from 2022. So I'll focus on that one. The definition of pulmonary hypertension is by hemodynamics, so invasive hemodynamics with right heart catheterization. By definition, it's the patients with mean pulmonary arterial pressure greater than 20 millimeters mercury. And then within that, there are three specific sub-definitions of pulmonary hypertension. The patients that we're most commonly seeing, perhaps especially in the cardiology world, is those patients with post-capillary pulmonary hypertension. So those are patients with elevated pulmonary pressures, secondary to elevated filling pressures on the left side. We don't often even think about these patients as having pulmonary hypertension per se. It's predominantly by cath. What we're seeing is an elevated wedge pressure greater than 15 millimeters mercury, with a normal pulmonary vascular resistance. Again, by the latest guidelines, that's pulmonary vascular resistance less than 2 Wood units. On the flip side are the patients with isolated pre-capillary pulmonary hypertension. So those are patients with normal left-sided filling pressures, wedge pressure 15 or less, and then the pulmonary vascular resistance, which is higher than 2 Wood units. Some of these patients also have what's called combined pre and post capillary pulmonary hypertension, and it's those patients with both elevated wedge and elevated pulmonary vascular resistance, perhaps due to reactive vasoconstriction of the pulmonary vasculature or further pulmonary vascular remodeling. And it's accepted in the guidelines and sort of in our community that perhaps PVR greater than 2 is really the definition cutoff, but clinically significant might be the patients with PVR greater than 4 or 5. That's the common definition that's being used in the sort of the clinical trials world, as well as patients with out of proportion pulmonary hypertension to the left-sided filling pressures. So those are the hemodynamic definitions that, it's a lot in the weeds, but it's very relevant for the treatment and management, as we'll see. In addition to that, there's the World Health Organization grouping. This is by history. Again, it's like the favorite, I think, student a sort of a question for students and residents on rounds is what are the 5 groups of pulmonary hypertension? So just to say kind of an outright, about the prevalence of pulmonary hypertension is considered to be about 1% of the world population, half of whom have group 2 pulmonary hypertension, and that's the ones secondary to left-sided heart disease. This can be from ischemic heart disease, non-ischemic valvular disease, and specifically for our cancer population, having higher prevalence of cardiac comorbidities, we may be seeing a higher prevalence of that as well. But again, these are patients from the hemodynamic definition will have isolated post-capillary and sometimes combined pre and post. About a third of the pulmonary hypertension patients will have group 3 PH, and that's secondary to lung disease. This might be interstitial lung disease or ILD. In our patient population, a lot of them will have environmental exposures, and that can lead to COPD or drug-induced pneumonitis that can further lead to things like pulmonary fibrosis. So again, our cancer patients will have higher risk of this. And then the last is that I want to mainly focus on too is that is considered more prominent, more prevalent nowadays is chronic thromboembolic pulmonary hypertension or group 4. So these are patients with pulmonary embolisms that perhaps are incompletely resolved, and then as a result develop pulmonary hypertension. In our cancer population, we'll also see pulmonary arterial obstructions from whether it's pulmonary sarcomas or mediastinal lymphadenopathy. So those are actually considered group 4 as well. And then group 5 is also something we need to consider in our cancer population, those with myeloproliferative disorders, myelofibrosis, and this rare entity we'll talk about later, pulmonary tumor thrombotic microangiopathy, or PTTM, which I think needs special attention in our population. And then finally, group 1 PH, and that's the group that we classically think of drug-induced PH or portopulmonary PH. It includes 2 in the general population, the idiopathic and heritable PAH, which tends to be sort of the younger population. But we'll talk more about these patients who have drug-induced PH from tyrosine kinase inhibitors and proteasome inhibitors, or such as carfilzomib.
Great. So I think that's like a super comprehensive outline of pulmonary hypertension, both from the hemodynamic side as well as the World Health Organization classes. Maybe if we could start with one of them, which is either the chemotherapy or the immunotherapy or newer agent therapy-related pulmonary hypertensions. So you were saying that most of these could be the group 1 pulmonary hypertension classes, but maybe if you could tell us your experience from MD Anderson. I know you've only recently moved, but even then, what is your feeling about these drug-induced pulmonary hypertensions in the cancer population?
Yeah, no, I'm very fortunate in that I have these amazing colleagues who've learned a lot about drug-induced pulmonary hypertension before my arrival, and Dr. Sadia Fayez is my main pulmonary counterpart. She has a quite extensive registry of patients with TKI-induced PH. Kind of to step back, these tyrosine kinase inhibitors, when they were, we know that they're commonly used for newly diagnosed or sometimes treatment resistant Philadelphia chromosome positive CML patients, as well as patients with ALL. And it's the initial trials comparing imatinib to dasatinib, where they found a signal for higher prevalence of PH in the dasatinib group. And then subsequently, when we looked at the larger, more focused PH registries, specifically the one that we've seen more data from is the French PH registry, where Dr. Jason Weatherald and his colleagues, they identified up to 21 cases that were just due to dasatinib PAH. And in this group, they found that, many of those patients after treatment discontinuation had improvement of their pulmonary hypertension, but almost 40% of those patients actually had persistent PAH. And so that's one of the questions that, Dr. Faiz and I are now looking at our own registry. These patients that we found in this retrospective cohort, there's about 20 of them with drug-induced PH, 15 of them who are previously on TKIs. We're finding that more of our patients are having improvement in pulmonary pressures and are being able to be weaned off of PH therapies. And so, the question I think still remains, we talk a lot about this permissive cardiotoxicity in oncology, in cardio-onc, and the question of, who are these patients who have recovery of their pulmonary pressures after discontinuations versus not? It's really about the iatrogenic factors, meaning the duration of TKI exposure, versus a patient factor, having prior history of, cardiopulmonary risk factors. And so I think those are really important factors that we need to sort of look at more closely in a granular fashion. That's still pending. But interestingly, we have seen through the pathophysiology of why TKIs induce PH. We think it's due to the one of the mechanisms that is sort of innate in our lungs. So there are these potassium channels called the TASC proteins that are modulated by tyrosine kinases, where hypoxia leads to overactivation of these potassium channels that then lead to calcium influx in the pulmonary vasculature, leading to vasoconstriction. And the whole point of the lungs being able to do this is that in the hypoventilated areas, those areas with hypoxia, we get to have some vasoconstriction as a protective mechanism to shunt the blood away from this underventilated areas to the better ventilated areas. Unfortunately, with TKIs, that ends up being sort of a more general, if you will, a vasoconstriction effect, and we think that that's why these patients end up having pulmonary hypertension, which means that perhaps by discontinuing this medication, we should have a resolution. But some patients, as I said, seem to have a persistent effect of this, and whether it's because of the prolonged effect or prolonged exposure to the drug versus patient-related factors, I think is a very important question to address moving forward.
Great. Yeah. So again, very comprehensive overview of the different types of drug-induced pulmonary hypertension, and really useful to understand the mechanisms there. I know there's lots of other types of pulmonary hypertension and lots of other mechanisms in terms of diseases and other things such as chronic thromboembolic pulmonary hypertension, as you mentioned. But maybe I'll hand over to Dr. Lenihan to ask some of these other questions.
Yeah, no, it sounds like we could really get way down into the weeds, and whenever you start thinking about pulmonary hypertension, what always happens, at least in my mind, is, okay, so say I found some degree of pulmonary hypertension in this patient, what am I going to do about it? And that's where the whole question of how did we get there? What were the situations that led to that? And the classifications that you already outlined, including the hemodynamic ones, are really intended to try to provide clarity. And then once you have that clarity, if it does happen that way, usually it doesn't, but once you have that clarity, then you have a recommended treatment. So there's going to be something that you do. So what seems like a common story to me anyway is, especially in our patients with cancer who maybe they've had some lung surgery in the past, and maybe they had some degree of left-sided heart failure, even with the normal EF in the past. And then they come in for either an acute problem, or they're just coming in for staging of their disease, and they get a CT and you see this big, huge saddle embolus. And so then you're going, okay, what do I do here? I've got maybe you did an echo to suggest some degree of pulmonary hypertension, and you have all of these conditions that make you more likely to have it. How do you separate that out?
Right. No, I think you asked the right question there. It's really highlighting the complexity of our patient population, with the kind of cardiopulmonary, comorbidities they come in. And then also, of course, as you mentioned, these incidental findings that come up, and how to address the pulmonary hypertension in that mix. How much is the pulmonary hypertension contributing versus the acute setting? I mean, one thing that I'll say about pulmonary embolism that's been very humbling, is when we identify these patients, about 50% of the time, it ends up being that it's not an acute process, that in fact, there was probably a chronic process. And of course, our cancer population, they're at 4 to 7-fold risk of developing VTEs. They have indwelling ports, which may be, nidus for thrombus and chronic thromboembolism. So the chronicity and the acuity of that finding that you're describing is tough to suss out, and exactly, how to manage and how to identify those patients with the quote unquote long-term sequelae, and when to trigger that sort of quote unquote chronic process of the disease can be tricky. And so, first and foremost, I think understanding the treatment of saddle PEs or, large thrombus burden. Dr. Wamik Youssef is one of my partners here who had been one of the first to kind of describe how do we best treat this underlying VTE, and is it really based on the RV dysfunction, the troponin elevation, NT-proBNP, what to do with the quote unquote intermediate risk PEs. And the reason why that's so critical is that we know for CTEPH, the underlying pathophys is that there's incomplete resolution of that PE that can lead to, over time, fibrin deposition, macrovascular obstruction. But not only that there's ongoing shear stress in the microcirculation in the well-perfused lungs to the point of developing microangiopathy. So kind of to come back to the idea of the PE treatment, first and foremost is effective management of that, and that can take forms of starting them on your run-of-the-mill DOAC, but also having very good follow-up for those patients. And I've been very humbled in that some of these patients seem to have anticoagulant resistant PEs, and so these patients do require, at the very least, a 3-month follow-up to see have their symptoms resolved. If the symptoms are persistent, as with many of our cancer patients, they have persistent shortness of breath for many different reasons, whether it's anemia, deconditioning, chemo. And so, if the symptoms themselves are not going to help you differentiate that factor, to do a follow-up VQ scan. And still in our PH community, we rely on VQ scans more than CT pulmonary angios. I know that,
it's pretty shocking, I have to say. I mean, yeah. I would be like, okay, so, if you just think about photography over the last 25 years,
right.
25 years ago, I would take an instant Kodak picture. If I went to a party or something like that, I'd take that picture and it would print out. And then at about, I don't know, 15, 20 seconds, the image would show up, and it would be pretty fuzzy, but you kind of get the feel.
And trust me, it's still fuzzy. It's
Yeah.
still fuzzy for
And
sure.
so there was, the Kodak picture 25 years ago, but now, of course, with your, practically anybody's cell phone, they get this really high quality, digital picture, crystal clear, et cetera. And then when I think about VQ scanning, I equate it to that Kodak picture.
Yes.
As opposed to a high resolution CT scan or something like that being a digital picture. So in the pulmonary hypertension community, they still go back to the Kodak instant picture.
Yes, and that's a very good question. Why is that? So again, it kind of has to do with the fact that CTPAs, they're very good at looking at the main PA, proximal vessels. But when it comes down to the segmental and subsegmental defects, that's going to be it's going to be a tough one to kind of have the right sort of resolution to look at the intraluminal defects in those tiny little pulmonary arteries. And again, the point here being that it's not necessarily the size of the defect that leads to severe pulmonary hypertension. It can even be sort of a diffuse, subsegmental disease that leads to significant pulmonary hypertension as well. And so that's why VQ scans ends up being a very important step for our screening tool that, current guidelines say for after 3 months of what we consider effective anticoagulation, we should be going back to a repeat VQ scan. And I will say one of the advances that we have been able to make in the past year is also following up some of those VQ scans with a pulmonary angiogram. So during the right heart catheterization, thanks to our biplane capabilities in the cath lab, we're able to do a pulmonary angiogram, not only selective but of the entire lung. And those areas where there were some questions of is this a truly matched defect where we have a perfusion defect because of some kind of pulmonary process going on, we can actually see that much better on a pulmonary angiogram, that there's actual pouch defect or a web defect, specific intraluminal irregularities that's going to help us define CTEPH above the other modalities. So that is a very important aspect of working up our patients in general for the cancer patients with PH. One additional thing that's really important that I've learned this past year is patients who appear to have CTEPH, there are some mimickers that are really critical to think about in our onc patients. The first one is this entity, pulmonary tumor thrombotic microangiopathy, or PTTM. By pathophys, sort of very simply put, it's a lot like CTEPH in that there are thrombi in the pulmonary vasculature. But in addition, there are tumors, so tumor emboli. And it's the microemboli, so it's not a patient who will have a macrotumor embolus and kind of, have a sudden acute RV failure and cardiac arrest. These patients will have more of a subacute, but rapidly progressive subacute onset of shortness of breath and PH. In most of the literature is coming from Asian countries where there's higher sort of prevalence of gastric metastatic adenocarcinoma, which has been described as one of the risk factors. And potentially there are some growth factors that are implicated. The tumor cells secreting PDGF or VEGF, these various growth factors that's leading to, or perhaps the pulmonary vascular remodeling and thickening. Since I've been here, I've seen several cases, and some of them have gone to autopsy, and we can actually see sort of the classic forms of what we call plexiform lesions in the pulmonary vasculature, where they have complete intraluminal occlusions from a dysregulated growth of pulmonary vascular smooth muscle cells and endothelial cells. So it's a very tough entity. And I guess the reason why I'm bringing this up is when we're thinking about patients with CTEPH, where you might see maybe small little emboli in the pulmonary vasculature, or perhaps some defects in the pulmonary vasculature, with a story of rapidly progressive shortness of breath, it's important to think about PTTM because the treatment may change. We may be a bit more aggressive about that chemo rather than waiting for this, right heart cath and all this, very extensive pH workup. You may be more aggressive about, talking to the oncologist, resuming the chemo. And in some, Asian literature, there's suggestion that PDGF inhibitors, imatinib, may prolong their survival because it's a growth factor mediated pulmonary vascular remodeling. And so, a lot more needs to be learned about why this disease, process is there. But certainly as far as the diagnostics, we've been more aggressive about workup for those patients when we're suspecting CTEPH, again, for this new entity, PTTN.
So I will say that since you're bringing up the concept of how do we deal with these recurrent thrombi, years ago, and I think the kind of the nidus for this expertise was in San Diego. One of the surgeons would do these thrombectomies basically, but they would be a 12-hour surgery or something like that, and they would dissect out very carefully all the thrombi throughout all the branches of the pulmonary artery and then pull it out kind of in one fell swoop. And so, I mean, just some of the images from those really what I would consider horrendous surgeries were just unbelievably impressive. Number one, just the patience to do that, but also just the extent of the thrombi. And then, of course, the outcomes of patients were quite good. If they survived the surgery, they actually did quite well overall. But then fast forward over the past decade, there have been a lot of techniques using, vascular extraction tools when a person presents with an acute PE, that you go in and, suck out the thrombus. Now, that's not available at every place by any means, but when it is available at the place that I'm working at, I have felt that it has made a huge difference. And so I don't know, for example, if you've had much experience with the acute thrombectomies or not, but I have certainly become a proponent of that. And it certainly looks like a less traumatic type surgery than that chronic major thoracic undertaking that I originally saw, 10 or 15 years ago.
Yes. Yeah. No, I'm so glad you brought this up. It's very humbling. I had seen one of those pulmonary thromboendarterectomies as well. Here, Dr. Mahesh Ramchandani at Houston Methodist Hospital is our local expert. And you're right, it's a complete circulatory arrest. Patients have to be cooled. There's there's a lot of concerns. Is the patient going to wake up at the end of the surgery? And it's a very prolonged procedure because not only are they going after the area where they saw the main occlusions, it's actually thought to be a diffuse process. So they go down to the segmental, subsegmental level as much as they can into both pulmonary arteries, trying to remove that sort of vascular remodeling that's occurred. So that particular procedure, you're right in that it's meant to be a curative intent, meaning that those patients have after the surgery, they rarely have, it's been shown to be very successful in reducing the pulmonary pressures and pulmonary vascular resistance, and many of them go on to not even requiring any medications afterwards to treat the disease. But when it comes to the thrombectomy patients, of course, these are the patients who have a fresh clot that's even capable of or amenable to being removed with a catheter. The CTEPH population is unique in that it's not necessarily the thrombi that we're removing or we're going after. It's the actual fibrinous vascular thickening, the scar tissue that's developed over time. And that's why, when we first see patients with concerns for CTEPH, first and foremost, the question is, do they have an acute PE? And if they do, then the thought process is to melt away those clots for 3 months before we even consider them in this CTEPH category. So, in this acute PE setting, can the catheter, directed from thrombolysis and thrombectomies, those procedures reduce the risk of CTEPH down the line? That's still being debated and developed. I've certainly worked with some naysayers who fear that could this potential approach worsen the distal thrombus burden by causing these clots to migrate more diffusely down the circulation. No one really truly knows exactly what happens to the CTEPH risk thereafter, but certainly in the acute setting, when patients are hemodynamically compromised, I think it's a very important and necessary tool in that sense. When it comes to, again, the CTEPH population, it's less, that disease is less amenable to the catheter-directed approaches of thrombectomies, but now there's a development and more focus on balloon pulmonary angioplasties as an option, because again, the idea being that perhaps it's the ballooning approach that can open up those tapered narrowed vessels secondary to fibrin deposition and further vascular remodeling, what the safety and whether this can help patients with cancer and CTEPH, that's still kind of the early stages. There's really one case report from Memorial Sloan Kettering from a few years ago on a patient with prostate cancer. And so I think as we discover and identify more patients with CTEPH in our population, we should really look at, I think, the impact that BPAs and balloon pulmonary angioplasties can have on their quality of life and 6-minute walk distance and things like that.
So Arjun, what has been your exposure or observations about the thrombectomy? Because what was just mentioned that when a patient comes in and they're hemodynamically compromised, then you proceed. Well, one person's hemodynamic compromise is not the same as another person's hemodynamic compromise. And if it was me personally, and I was pretty short of breath and I had a big thrombus, I probably would appeal for somebody to scoop that out of there if they could.
Yeah, thanks, Dan. I think I was just mentioning off camera, off the podcast, that probably depends a little bit on where you work in the UK as to what your local experience and exposure is, and also what availability you have for the chronic thromboembolic pulmonary disease type of surgery. So we definitely have referred some patients, and some of these have been cancer treatment related or cardio-oncology patients. And I think coming back to those acute patients that come in extremis with hemodynamic compromise, we do have the option again of the emergency thrombus retrieval, aspiration, and surgical approaches to removal. So I think it's nice, of course, to work in a center where you have access to that, but maybe that's not uniformly available across the UK.
Well, thank you, everybody, for another great episode. We appreciate your insights as always, and I want to encourage all of our listeners to go to GCOS 2024, GCOS 2024, through your web browser, and there you'll find registration information for our global summit, which is coming up in Minneapolis, Minnesota, September 21 to 23. We hope to see many of you there. Thanks for joining us. For more information about ICOS, you can go to ic-os.org, where you'll find more information about all of our programs, including our weekly webinars, our board certification exam, and other resources that we know you'll find helpful. Thanks for joining us today, and we hope to hear from you soon.